So, guys, welcome to this session of ENT, where we are going to discuss some topic, and then we'll also discuss few MCQs. At the end, if you have time, we'll discuss few MCQs. The topic that we are discussing is basically a case presentation, which is actually a very important topic, which is like when a patient presents with nasal blockade. I'm sure everybody will appreciate, even if you have not attended any clinical setting, you have never seen a patient, you'll know that in ENT, this is a very, very common complaint, that a patient comes to you and tells you that the nose is blocked or the patient is not able to breathe. See, it's a very open-ended question line. I've not used the A's. I've not told you what sex the patient is. I haven't told you which side, one side or both sides. I've not told you, is there any other history, any other relevant points, discharge. So it's a very, very open-ended question, which means you can proceed in this case in any manner that you wish to, whatever you wish to. So that's the beauty of this one line. That's why I've just used one line, so that you can proceed the way you want to. Now, when the patient says that I present with, when the patient comes with nasal blockade, first thing is, what are the possible diagnoses that comes to your mind? That's the first thing, because that's how you do. When the patient comes and tells you, first thing is, it's always like a chapter opens in your mind. What are the possible diagnoses? And then one by one, you have to rule out. First with your history. In history, it's history related to this present symptom. Then maybe past history, family history, any other associated history, drug history, things like that. And then if required, you may have to do examination, which is often done, and then investigate the patient to confirm the diagnosis and treat accordingly. That's the sequence that we always take. Now, first thing is, when the patient says, I have nasal blockade, what are the possible causes of nasal blockade? And this is the list of common conditions where nasal blockade can happen. And I've divided these causes of nasal blockade into two categories, in this case, children and adult. So in children, common causes of nasal blockade are foreign body in the nose, very, very common, septal hematoma, sometimes divided nasal septum, encephalocele, gliomas, tumors of different kind. There are some tumors which are seen in children. Adult, on the other hand, the common causes are nasal polyps, DNS, inferior turbinate hypertrophy. This can be either isolated or due to sinusitis. So I can add sinusitis at the end, because sinusitis can also cause the same thing, which is sinusitis, right? So hematoma on the in the nose, angiofibromas, tumors like angiofibroma, inverted papilloma, carcinomas, and of course sinusitis can cause. So when these things comes to your mind, you have to rule out one by one and then try to arrive at a conclusion. So what are the things that you have to make note of in this patient? See, one is, I'll come to this causes again. One is you have to make note of the age. So as I said, I told you what are the common causes of nasal blockade in children. The list is already here. These are the causes of, but so one is a child, young age. So like juvenile angiofibroma, very specifically seen in young boys. You all know the name is juvenile, and adults. So you have to make the note of the age of this patient, which is not mentioned in the question. Then the sex, male or female, because again angiofibroma is exclusively seen in males. Most of the carcinomas are seen in males. There is no disease of nose which is exclusively seen in females or which is more common in females. So they are all male diseases more commonly, and some of the diseases could be equal in males and females. So this particular point is not very relevant in nose, except if it is a young age where you suspect an angiofibroma, because angiofibroma, as I told you, is always seen in males, not in females. Then unilaterally, is it unilateral or bilateral? This is blockade. See, this is important because let's say hematoma in a child is always bilateral, right? Ethmoidal polyps are always bilateral. So there are some diseases which are already bilateral, and most of the diseases could be unilateral. DNS could be, not always, maybe bilateral, but most of the conditions cause unilateral blockade. The disease which will always cause unilateral are foreign body. FB is almost always unilateral. Maxillary carcinoma, maxillary polyp is again almost always unilateral, and tumors also tend to be unilateral. Turbinate hypertrophy again tends to be unilateral. So especially if it is bilateral, unilateral does not give you too much of information, but if it is bilateral, then it gives you a very limited thing that these are the possible. And sinusitis, bilateral sinusitis, of course, bilateral, right? Now before we proceed as to how to rule out these causes one by one of nasal foreign body, I want to tell you about one very common thing which is called nasal cycle. Now before I talk about this, I already told you that we'll discuss this topic, and then at the end of the topic we are also going to take few MCQs. So I've prepared some MCQs based on this particular topic, so we are going to take some MCQs also. So nasal cycle, as you know, that even normally, what is nasal cycle? Even normally your inferior turbinate increases and decreases in size. It hypertrophies and shrinks, and hypertrophies and shrinks, and this happens normally also to the inferior turbinate. And this is because inferior turbinate has a tissue which is very similar to the erectile tissue. The tissue of the inferior turbinate is very similar to the erectile tissue, and like erectile tissue, it can expand and shrink. So normally your inferior turbinate behaves like an erectile tissue, and therefore it expands and shrinks from time to time. An interesting bit is that this happens alternatively. Once, let's say, right side will expand, the left side will decrease. Then the right side will shrink, the left side will expand. So they go like alternatively, like this, right, left. and this keeps happening throughout the day and throughout your life, and this is called the normal nasal cycle. So it is cyclical one. It shifts from one side to other side, which also means that at any given point in time, both your nasal cavities do not function equally. One side is always functioning more than the other side, and because it has been happening right from our childhood, we are not aware of this. Our mind and our subconscious mind is used to this, right? And we don't know about this. But some people, if they're very sensitive, they become aware of this fact, and if they don't know that this is a normal thing, they get disturbed. They think it is a problem that the nose is blocked. So this another thing, the patient will come and tell you, my nose is blocked. And if you ask the patient, since when, they'll say very long time. And you ask which nose, they'll say sometimes this one, sometimes this one. Kabhi ye, kabhi wo, And straight away, if long history and there is no other problem, only nasal blockade, alternatively cyclical, then it is a normal nasal cycle. Now, why do you think we have a nasal cycle? Why does nature have this nasal cycle? Why not both the nose remain same all the time? Why the inferior turbinate shrinks and expands and having nasal cycle? There are two theories to it. There is no confirmation why this happens, but there are two theories. One says that, it's very logical that you breathe and the air flows to the nose. So if the nose is wide, if the cavity is wide, the speed of the flow is very fast. It's relatively fast. But if the nose is constricted, then it's a slow movement. The flow is slow. Now, the chemicals that we inhale, which is responsible for sense of smell. So this is related to sense of smell. They have to bind to the olfactory epithelium. There is olfactory epithelium at the top of the roof of the nose, and the dendrites of the receptor cells are hanging down. And the chemicals that gives you a sense of smell, they go and bind to these receptor cells, and they remain there for fraction of a second, and that creates an action potential, and then action potential travels to the nerve, to the brain, and then you perceive that smell. So now the thing is, they say that some particles need more time to adhere to these receptors to give you that sense of smell, to create the action potential, and some particles need to remain there for a long duration of time to create the action potential and give you a sense of smell. So some particles need short period of time, and then they have to move on. Some need to remain there for a longer duration of time, and then they move on, because they will move on, so the next set will come and then bind, and this is a cycle things. So they say that if you have different speed of flow in the two nose, so this gives chance to both this type of particles to create action potential and give you a sense of smell. They will go and try to bind to both the sides, both slow particles and fast particles, but in the side where the nose is wider and the flow is faster, the slower particle can create the action potential, the faster cannot. They get pushed. The air flows, they get pushed. So in the fast side, the one which needs more time to create action potential, which is actually slower. These are slower particles. They cannot create action potential. Before they can create action potential, they are pushed off by the next breathe, next flow. But the faster particles who can generate the action potential very fast, they create the action potential and you get the smell. You don't get the one of the slow. On the other side, which is where the nose is flowing slowly, here the particles which are slower, which takes more time, they will keep binding for a long period of time. They will not allow other particles, the faster particles, to bind, and they will generate action potential and give you the sense of smell. So you get both smell of both the particles, the faster and the slower, so you can perceive wider range of smells. And this is one of the theories, and that's why we have this nasal cycle, and this keeps alternating. So one is this: we don't know whether it's true or not. Like I said, it's theory. The second theory is that nasal mucosa gets damaged very fast because it's working all the time. You are breathing all the time, and every breath that you breathe in, a lot of pathogens are coming in, a lot of particles are coming in, and they are creating toxins. They are damaging the tissue. Temperature, because nose is the first thing that comes case exposed with outside temperature. You breathe through the nose. If there's very cold weather, you breathe in cold air. If it is very hot weather, you breathe in hot air. And the nose will have to regulate this temperature. One of the functions, as we know, of the nose is regulation. So your tissue of the nose is working very, very hard and very, very fast, and so it needs to regenerate very fast. They get damaged very easily, and they need to regenerate very fast. If your nose are constantly working equally, then there's no sufficient time for regeneration. So they say that the faster the nasal in this nasal cycle, the nasal cavity which is wider does not get time to regenerate. The tissue of the nose do not get the time to regenerate. They are functioning mainly. They're taking the care of the function of the nose. Whereas the nose which is blocked, where the turbinate is hypertrophy, where the airflow is very limited, this is not functioning now because the airflow is very limited. So it is not functioning to its full potential, and so this tissue gets time to rest, to time to regenerate, the regrow, regenerate, and by the time they are fully grown, then it will shift. This cycle will shift. Now this nose which was regenerating now starts functioning properly. It takes care of the whole function, and the other side now the turbinate hypertrophies, the flow decreases, and now this side the tissue starts regenerating, and this keeps on going. So what happens is you are getting full flow also, and your nasal tissue have sufficient time to regenerate, and the nose have sufficient time to function. So one of the causes of nasal blockade could be this nasal cycle, and it's a very, very common problem. I'm telling you that almost 20% of the patients who come to us have this problem of nasal cycle, and they don't know, they are not aware of this. They'll say that I have nasal blockade, and if you ask them how long, it's usually a long history, and they always say alternative, kabhi ye, kabhi sometimes this one, sometimes this one, and then it becomes very difficult to explain to them that this is a normal physiology of the nose. This is called normal nasal cycle, because uh, most of the time they will have talked to their parents, their siblings, brothers, sisters, or friends, and they'll ask, it happens to me, does it happen to you also? And everybody, because we are not aware of it, it happens to all of us, but since we are not aware of it, most of us think that no, I don't have this problem, and the patient thinks that I'm the only one who have this problem. And if you tell this patient this is a normal thing, everybody has it, he or she will definitely tell you, I've discussed with my parents, I've discussed with my brother, I've discussed with my sister, my friend, none of them have this problem, only I have this problem, so how can it be normal? And so it becomes very difficult to convince this patient that no, it is actually a normal thing. Now it becomes a little simple for me. What I do is, one of the things I do is I write this name nasal cycle in his prescription paper, and I tell them go and Google this term and read about it. So when they Google this and read about this, and then when the Google tells them, various articles in the Google tell them that this is a normal cycle, then they get more convinced. So it's easy to convince now once they read in the many articles in Google's, then they get convinced. And once you know that this is a normal thing, then actually the problem is gone. So always keep this one in mind. But we are more concerned about these causes. So first of all, I'll come to this. When the patient comes to you and tells you I have a nasal blockade, what are the most important things that you have to ask? What is the most important history that you have to take? We have to ask history of nasal discharge. Does the patient have discharge also or not? Unilateral or bilateral? Fever, pain in the nose, not only nose pain, sinusitis can all cause pain in the teeth, pain in the ear, pain in the head. DNS can cause headache. So pain anywhere, pain, discharge, then blood flow or blood stained nasal discharge, things like that. Sneezing. This discharge can be watering also. You can use the word watering of the nose, sneezing. History of trauma, history of drug intake, family history. Anybody in the family has this? Past history. Did the patient have past? If it is yes, how frequency the patient has? When did it start and all that? So any other systemic problem. Weight loss, because in tumors, hearing loss, because if the station tube gets blocked, the patient might have hearing loss. So a lot of things you have to ask this patient. And then you have to do, the most important thing is you have to do the examination of the nose, which is anti-rhinoscopy. AR, we call it anti-rhinoscopy. For that, most commonly we use the thudicum, speculum, but they are the like Killian's, Cottle speculum. There's a Cotter's test also. There's Cottle speculum also, right? You may have to do posterior rhinoscopy. You have to do endoscopy. Patency test. Patency test means you check whether the flow of the nose, air through the nose is normal or not. Then, if you suspect sinusitis and all, trans-illumination test might be required. Trans-illumination test might be required. In case of DNS, you might have to do Cottrell's test. We'll discuss all this. I'm just mentioning now. And once you have done all this, you might have to investigate. Investigation, CT scan is very commonly done. DNE is diagnostic nasal endoscopy, and X-rays might be required. And we know about X-ray views. This is not the topic for X-ray views, but some other time we have to talk about X-ray views, because X-ray views of sinuses are very, very important from the exam point of view. So these are the main thing. This is general, how you approach the patient. What are the history, important points in the history? What are the examinations and what are the investigations that generally are done? But we'll take one by one, this one by one, and talk about them, that what are the points in favor of this diagnosis. So one is, when you have this list in your mind, when the patient comes and tells you, I have nasal blockade, and you don't know, it could be any of these. So suppose you have this list in your mind and you want to rule out one. So when you suspect foreign body in the nose, as I said, this is most commonly seen in children. The patient has to be small child in fact. Adults usually don't put the foreign body in the nose, they're careful. And even if it goes in the nose by accident, sometimes in adult, most of the adults will remove it by themselves. So they will not be required to go to the hospital. But children, very common one, and when they try to remove it, it gets pushed more and more inside. So that's the problem. It is often unilateral. So if it is bilateral, it is perhaps not a foreign body. And usually there is foul smell and maybe plus minus bleed from the nose. So this is, and oftentimes the child is scared. They know that you can make from the face of the child is scared, because they know from this that they feel guilty, they feel they have created a crime. Because oftentimes when the child has this problem, the parents shout at the kids, and they know that doctor ke paas jana padega, and most kids are scared of doctors. So they are scared. So they have a sense of guilt in them. So diagnosis is very simple. If a child has unilateral foul smelling and bleed, it is straight away foreign body. In most cases, if you do a rhinoscopy, you can see the foreign body. Sometimes I told you that when they try to remove it themselves, the kids, they only push it further and further deep inside, and sometimes you cannot see them. And so you may have to do endoscopic examination. Now, X-ray and all will not show. Most of the foreign bodies are not metallic, they are non-metallic. It could be just a piece of paper, and these things cannot be seen on X-ray. So X-ray is most case useless. Endoscopy is useful if you can't see, and if the foreign body has been there for a long duration of time, it may become what is called rhinolith, isn't it? We know what is rhinolith. If the foreign body has been there for few days, it could be a rhinolith, where there is a deposition of calcium on this foreign body and becomes hard like a stone. Now, if you take an X-ray, you will be able to see, but in most cases you cannot see this. So these are the points. Then what are the points in favor of septal hematoma? Most probably there will be a history of trauma or fall. The child, again, it is a child, most commonly. The child was playing, and while running and all, the child fell down, the nose hit something, and hematoma. So that's trauma. Very, very important. Now, it is always bilateral. Septal hematoma is always bilateral. So there's going to be a swelling on the septum on both the sides. So when I always draw the septum like this, like this. So when there is a swelling on the septum, it is like this due to hematoma. So there is a blood collection here and a blood collection here, bilateral. So when there is a trauma on this nasal septum, either there is a hematoma where there is a blood and the blood has not come out, see, but it may cause epistaxis. If there is a breach in this mucosa, if the mucosa tears happen here, suppose this one, so suppose there is a tear here, so what will happen? This blood will not collect inside, it will come out, isn't it? So that's epistaxis. And third is fracture of the septum can also happen, and fracture can lead to DNS. So these are the things that can happen in trauma of the septum. So one of the things is hematoma. We are not talking about the rest of it. We are not talking. This topic is about nasal blockade. See, epistaxis fracture may not cause nasal blockade. DNS can, but DNS we have discussed. Our next topic is DNS, so that we'll talk about. So this is the main thing. Now, oftentimes, like I told you, when there is a hematoma in the any swelling in the nose, especially in kids, because the nasal cavity is very narrow. Now you don't know where the swelling is coming from. Is it on the septum or the lateral wall, or coming from inside, like sinus and all that? So sometimes it becomes, if you know which wall it is coming from. See, let's say inferior turbinate hypertrophy is this one, and septal hematoma, the one which is inferior turbinate hypertrophy is lateral wall of the nose. Septal hematoma is the medial wall of the nose, and if you have nasal polyp, which is coming from the sinus, so that is coming from posterior end of the nose inside. So it is neither medial wall nor lateral wall. It's come from inside. Now you don't know, because the whole nasal cavity is filled with this mass, and you don't know which wall it is coming from. So what we do is we take a probe. Suppose this is a swelling. Okay, we take a probe and we pass around the swelling and the wall of the nose, and we try to take the probe around this growth. We want to take it around this growth like this. So obviously, so suppose it is coming from the middle wall, it cannot go all around easily, because when you come to the middle wall, it gets stuck. It cannot cross it because there is a middle wall there. Similarly, if it is coming to the lateral wall, when you come to the lateral wall, it cannot go around there. It will get stuck. There will be a resistance. There will be a blockade. But if it is coming from posterior end, like a polyp, then it can go all around. So if it is going all around easily, that you know that it is neither middle wall nor lateral wall. It is come from somewhere deep inside. So this probing and going around this swelling can at least tell you which wall it is coming from. And it's very useful in this septal hematoma, because septal hematoma is from the septum, medial wall. And the child is usually not giving history, because this child is also fallen down. The child may be crying. You're not sure what is there. And if you can know that this is coming from the middle wall, then you are absolutely sure it is septal hematoma. And then you can do this probing, and it's quite useful in making diagnosis. And this is especially important in septal hematoma, because in septal hematoma, the incision and drainage has to be done immediately. We don't delay in the incision and drainage, because otherwise the septal hematoma tends to cause ischemia, necrosis, and septal perforation. Septal perforation in these patients are very, very common, and septal perforation is a very bad condition to have. So it's better that we prevent septal perforation. Next is, so incision and drainage in septal hematoma has to be done immediately, and that's why it's better that you try to investigate and confirm that it's septal hematoma, so that you can do the treatment, prevent septal perforation. DNS can cause septal nasal blockade. We all know DNS is usually a condition right from birth. Usually it's due to birth trauma, but in the beginning it is not too much. As we grow, because septum is still growing as we age. The septum, I'm sure you know, completes the growth by 17 years, 16 to 17 years. So in the beginning, the DNS may be mild, and towards the adulthood, towards puberty, the DNS becomes more prominent, and the patient begins to have a problem of blockade. So in childhood, it's not as common, possible, but adult, it is going to cause obstruction. Now, one thing about DNS is, that let's say this is the nose. Okay. Now, if you have a DNS like this, see, like this, then it will cause obstruction only on this side, the DNS part, one side, unilateral obstruction. But if you have a S-shaped deviation goes like this, which is pretty common, S-shaped deviation. See, now it will cause obstruction this side also, and from here this side is bilateral obstruction. So DNS can cause unilateral obstruction, bilateral obstruction, and even in unilateral obstruction, this one, what happens is usually the other side, the normal side, there are three turbinates like this. This inferior turbinate becomes hypertrophied like this, inferior turbinate hypertrophy, and this hypertrophy of the inferior turbinate can cause obstruction. Now again it is bilateral obstruction. Now in this bilateral obstruction is not because of DNS. One side is DNS, the other side is due to inferior turbinate hypertrophy. But this is bilateral obstruction, both are due to DNS, one at this level and one side, one at this level, because it is a S-shaped deviation. So point is, DNS can cause obstruction on one side, it can cause obstruction on both the sides, and one side DNS can cause other side obstruction due to compensatory hypertrophy of the inferior turbinate also. Now Avinash is asking, he's saying, Avinash, you're asking about rhinosporidiosis, which can arise from the medial wall, and how will it differentiate from hematoma? Yeah, in one thing is, in rhinosporidiosis is never seen in children, it is seen in adult. Hematoma is always seen in children, most of the time it is seen in children, very uncommon in adult. That's one thing. Hematoma has a history of trauma, rhinosporidiosis does not have a history of trauma, and rhinosporidiosis is very different to look, it's strawberry. So it's a deep red color. Hematoma is never deep red. You can see a mucosa over it. You can make out there is a mucosa and there is a collection within the mucosa. So the mucosa is shining. But rhinosporidiosis is fleshy red, deep red, and there are white dots on it. Usually the spores, white dots, and the look is like a strawberry. That's why rhinosporidiosis is described as a strawberry polyp. So I'll talk about that also. Anyways, then so DNS, I told you, most of the time DNS, if it is causing obstruction, we'll have to do surgery, septoplasty or SMR. Encephalocele. Now this is seen usually in newborns. Usually it's a congenital defect, encephalocele, where there is a developmental defect as a result of which the skull base is not completely fused. The bones of the skull base are not completely fused. There is some dehiscence there, and so the cranial tissue herniates through that, carrying CSF with it, and it comes first to the nasopharynx, and if it is too big, it comes to the nose also. In the nose, it's less common, but it's usually in the posterior part of the nose, nasopharynx, and will cause obstruction. So it can cause obstruction, usually unilateral, can be bilateral, very, very uncommonly. Right? Most of these encephaloceles are still connected with they still have a connection with the nasal cavities. So because it is blocked nose, it will cause some discharge also. The discharge of the nose cannot flow back, so there is discharge from the nasal cavity, and they often get infected. So sinusitis, rhinitis, foul smell, all that may be there. Now, one thing which can help you differentiate encephalocele from any other growth, especially in a very, very small child, is that when the child is very small, as I said, newborn, few months, maybe 1 or 2 years, and if there's a nasal mass with nasal blockage, there is a very high suspicion. So you have to have a high suspicion of encephalocele, because in a small child, growths in the nose are very uncommon. A 2-year child will not have trauma, hematoma, because the child doesn't go out. The child remains in the house with mother and all that. And because small children are under the vision of the mother, supervision of the mother, foreign body and all things are very uncommon. All this starts, hematoma, foreign body and all, when the child starts playing outside, starts going outside 3-4 years later. So less than that, if the child has a swelling in the nose, the suspicion of encephalocele will be very, very high in your minds. Now, one of the things that you can do clinically to confirm this is a sign called Furstenberg sign, for those who know. Furstenberg sign. What happens is, as I said, because this growth is connected with the cranial cavity, and small children, they cry a lot, we all know this. So every time the child cries, we all know when you cry, your intracranial pressure rises. So every time the child cries, the pressure in the brain rises, and that brain pressure gets transmitted into the encephalocele through that connection. So this encephalocele expands. So every time the child cries, this encephalocele expands every time the child cries, and this is called Furstenberg sign. And it's very useful in diagnosing encephalocele, but ultimately it has to be either CT scan or MRI. Usually CT scan, because you want to see the dehiscent part, bony dehiscent part is seen better in CT scan, but because the thing is soft tissue, the encephalocele, and so it gives you, MRI gives you that kind of information. So both people, most of the surgeon will prefer that you get a CT scan as well as MRI to get complete information, and then of course surgical correction has to be done. Now, gliomas is same thing. When encephalocele, if the connection breaks, that connection between the skull, brain, and the swelling breaks up, then there's a collection. This collection becomes hard. It's not fluid anymore. Most of it becomes hard, solid, and now it's called a glioma basically. So it's extension of the encephalocele, you can say, in a way. And although tumors in children are very, very uncommon, but there are possibilities of tumor, and then you have to take biopsy, do a histopathological examination, and maybe confirm. And all these are surgical treatment, whether it is encephalocele or gliomas or tumors. You have to do surgery, and you have to investigate properly for with CT scan, MRI, maybe biopsy, and histopathology, and all that. So this is how you go about when there is a growth in the nasal cavity. Now, growth in the adults, which are more common. One of a very, very prominent growth is nasal polyps. Nasal polyps are pretty easy to diagnose actually. See, there are two common polyps. One is a maxillary polyp, and the other is ethmoidal polyp. Now, maxillary polyps are more common in children, pediatric age group around 10-12 years. This is adult. Maxillary polyp is unilateral and single. This is bilateral and multiple. They look like bunch of grapes. Ethmoidal polyps are described as bunch of grapes, and they are pale in color. So the two very important things that can help us differentiate a nasal polyp from any other condition, both this applies to both maxillary polyp and ethmoidal polyp. They are usually pale in color, and B, there is no history of bleeding. Even if you probe, if you touch it, even if you prick it, they don't bleed. Even pricking will not cause bleeding. Maybe just the prick, that one very small drop may come out, but then it'll stop. It will not bleed continuously. Otherwise, nasal mass, nasal growth, turbinates, they bleed profusely, because nose, I'm sure you know, has a very rich blood supply. 5 arteries in the nose. Nose really has a very, very rich blood supply, and that's why the nasal thing tend to bleed a lot especially when you handle it. But polyp is not going to bleed unless it is infected. When there is infection of the polyp, then of course it might bleed. Usually it does not bleed, and it is also insensitive to touch. So these are very classical feature of nasal polyp, which are different from any other disease of the nasal cavity. They are pale in color, they do not bleed even on probing, they are insensitive to touch. And once you look at it, because that color, that pale color is so classical from any other thing, that once you see a nasal polyp, you never forget it easily, right? But again, you can confirm with the help of either endoscopy or a CT scan, because CT scan anyway has to be done. Ultimately, nasal polyps, surgery has to be done. Most of the nasal polyp will require, maxillary always requires surgery. Ethmoidal, in most cases, after a course of steroid, you still have to do surgery in most cases. So almost always you'll have to do surgery, and before surgery of the polyp, CT scan is mandated. It's like a gold standard investigation for nasal polyps. You have to do it. So that will confirm the diagnosis. In most cases, as I said, the first look will tell you it is a nasal polyp. Once you experience, it is very easy to diagnose this one, differentiate. So very, very easy. And in nasal polyp, one of the things is that there are many, nasal polyp is not a disease actually. Nasal polyp is like a presentation or a symptom, like fever. Fever is not a disease, it's a presentation symptom. So you must be able to find the cause of that symptom. So this is the problem with nasal polyp, that you must be able to find the cause of this nasal polyp. Most of the nasal polyps are due to allergy. Infection can be caused. There's syndromes like Semter's triad, Carter-Gainer syndromes, Young syndromes. Then kids with cystic fibrosis, there's so many conditions where nasal polyps can arise. Allergic fungal sinusitis is another thing. So you must be able to diagnose the cause of the nasal polyp and try to treat the cause also. Otherwise, if you don't treat the cause, the cause, whatever is the cause, is going to create problem, and B, the chances of recurrence becomes that much higher. Because if you don't treat the cause, the basic cause, the underlying cause, then of course the cause remains and then create another polyps. And this is a problem, recurrence in nasal polyps, because most common cause is allergy related. Normal allergy or allergic fungal sinusitis or allergy of Semter's triad. Semter's triad is also a systemic allergy actually in a way. So most of the cases of polyps are allergic in nature. I'm sure you know allergy cannot be eradicated. Allergy can be suppressed, allergy can be controlled, allergy cannot be eradicated. So that's the problem with nasal polyps, that you cannot, in most cases, cannot treat it properly. So the patient has to be on medication and follow up regularly. So that's the problem. DNS in adult is very similar to the DNS in children, as I said, but also I told you that DNS in adult is more common because when we are born, the septum is still growing. So whatever little bit of DNS is there in the childhood will become more pronounced by adulthood, and the real symptoms will start when the patient becomes really adult. Inferior turbinate hypertrophy is another very important cause of nasal blockade. Now, inferior turbinate hypertrophy could be just an isolated problem, the turbinate hypertrophy, because remember I told you that inferior turbinate has a erectile tissue in it. That's why it can expand and shrink like any erectile tissue, and this is the cause of nasal cycle, a normal nasal cycle. So sometimes the hypertrophy stage remains for too long, and then hypertrophic changes happen, some fibrosis happen in it, and the turbinate remains hypertrophied permanently, and it becomes an inferior turbinate hypertrophy as a problem. The other important cause of inferior turbinate hypertrophy is DNS. If one side has DNS, the other side inferior turbinate hypertrophy is to compensate for the extra space. I explained to you. Like in this case, look at this diagram that I've shown here. There are 3 turbinates here, like this, and 3 turbinates here, and the patient is DNS. So this space is too much. So this inferior turbinate will hypertrophy like this to compensate for the extra space, and this is inferior turbinate hypertrophy, right? And sinusitis is the third cause. Sinusitis because of recurrent infections, recurrent trauma to the infective pathogen will cause trauma, and that will cause that hypertrophy of the turbinate. So inferior turbinate could be an isolated case. It could be due to DNS compensation. It could be due to rhinosinusitis, but the problem is the same. The turbinate is hypertrophied, and it obstructs the nasal cavity and causes the blockade. Some books use that if it's too much hypertrophied, some books use the word mulberry turbinate. Mulberry turbinate. Now, turbinate hypertrophy could be hyperemic and hypertrophic. Hyperemic, as the name tells you, is hyperemia. There is redness. This is acute problem of the turbinate. Acutely, it is hypertrophic because of congestion and edema. Congestion and edema. And because this hypertrophy is hyperemic, it's congestion and edema. So when you pit it, if you take let's say probe and you push it, you can see there's a depression, there's a pit form. So if the pit is forming because the edema, because of the pressure, the edema goes out of that area, it travels outward. So there's a pit. So when you look at the pit, it is a hyperemic edema congestion, and so it's easy to do. It's a reversible stage. All you have to do is you have to treat the edema part, the congestion part, and the thing gets treated. But the second type is hypertrophy. There is a proper hypertrophy of the tissue. Like you can see, there is a fibrosis of the tissue, and now there is no pitting, there is no edema, no congestion, no pitting, and this is irreversible stage. You have to do surgery. So turbinectomy might be required. Turbinectomy. And turbinectomy is another topic which we'll discuss sometime because it's a very important topic nowadays. There are many methods of doing turbinectomy. There are many types of turbinectomies, plastic surgery and all that. So turbinectomy is some point in time I want to discuss with you guys. So look out for that video. It's an important topic. One of the things turbinectomy can do is it can cause a syndrome called empty nose syndrome. So we'll discuss that also sometime later. Empty nose syndrome can happen in a patient of turbinectomy. So hematoma, next one. Like in children, hematoma can happen in adult, but it's very uncommon. Let's talk about sinusitis first, the last one. Now sinusitis, again, one of the sinusitis is an inflammation of the sinuses and nose. Rhinosinusitis is called it. One of the complaint is nasal blockade. It's not always there because in this case usually the cause is either there is a collection of pus in the nose or the middle turbinate goes into hypertrophy a little bit, and that can cause obstruction. And we all know this, that you have to treat with medicines first and maybe surgery be required. Then we talk about tumors. Angiofibroma, I already discussed. Angiofibroma is also called juvenile nasopharyngeal angiofibroma. This is seen more commonly in children, in young age, young males. It is never seen in females, it is never seen in adult. And because it is seen in a certain age group in males, it is very easy to diagnose. Let's say if a 10-12-year-old male child comes with epistaxis, because it's an angiofibroma, as the name tells you, it's a vascular tumor, angio. Uh, so there's a vascular tumor with a lot of fibrosis, there's a fibroma. So it bleeds a lot. It bleeds recurrently, it bleeds massive. Every time there's a bleed, it is a massive bleed. So, but first bleed may be surprising. There's a angiofibroma, it has grown to quite a big size, and the patient never have had bleeding. Little bit of nasal blockade and all that, patient ignores. The moment the patient it starts bleeding, the patient gets alarmed and the patient comes. Usually the patient comes not with blockade. The history of bleeding is the first presentation in most cases. And if you ask this patient, did you had bleeding nasal obstruction in the past, they'll say yes. They'll give you a positive history of nasal blockade, but they never came with that. They came in only when the bleeding started, right? So again, it's all tumors are altogether different ball game. You have to properly examine, investigate, and then they have serious implications. And treatments are usually surgery or radiotherapy or chemotherapy, depending on the type of tumor. And in this, we cannot discuss tumor because tumor is a big topic altogether. We have to have a separate chapter for that. But they are very much causes of nasal blockade, and you have to have a very high index of suspicion to diagnose them, because we cannot afford to miss them even for few weeks, because by the time the patient comes back again, it might change its stage from stage 1 to stage 2, and the prognosis changes dramatically as the stage changes. We know this. Sometimes the treatment options also change, so you have to be really, really vigilant to be able to diagnose them on time. So a young boy with nasal bleeding, cheek swelling, things like that, and there's some signs, enteral sign, Hallman-Miller sign, all that things. You have to be mindful of all those things. Inverted papilloma is one of the very common benign tumors of the nasal cavity in adult males. So this is adult male, more than 50 years male, and it's always unilateral. There's a swelling on the middle meatus, so lateral wall of the nose, and bleeding is often associated with nasal blockage. So only nasal blockade is not the complaint. Bleeding might be the first complaint. Again, in tumors, bleeding might, in the nose and the sinuses, bleeding might be the first complaint. So patient may come with bleeding, and when you examine, and obstruction of course, when you examine, you can see a growth in the lateral wall of the nose, and if you take a biopsy, it will confirm that is inverted papilloma, which is also called Ringer's tumor, by the way, and then you can diagnose. Now, carcinoma of the nasal cavity is uncommon. Carcinoma of the sinuses are more common compared to the carcinoma of the nasal cavity. And when you have carcinoma of the sinuses, whether it is maxillary sinus or ethmoidal sinus, then obstruction is less common. But if the carcinoma is the nasal cavity, which is very, very uncommon, then of course there can be obstruction. But again, carcinoma, like I told you, tumors, bleeding is very common, and they can cause accumulation of the discharge, foul smell, and all that. So associate a lot of symptoms are possible. Then we have few granulomatous disease. There are two important diseases. One is called rhinoscleroma and rhinosporidiosis. So these two conditions also should come to your mind. Now, the first one, rhinoscleroma has 3 stages. There is a stage of atrophy, there is a stage of granuloma formation, and there is a stage of sclerosis. And it's an infective disease caused by Klebsiella rhinoscleromatis. In India, it is seen in the semi-desert like area, arid area, Rajasthan, Punjab, Haryana, parts of Delhi, and Gujarat, this belt, Western India, you can say. This pathogen grows very well in this semi-arid areas. So in the first stage, when there is atrophy, there is atrophy of the nasal cavity, so there is no obstruction. But in the next stage, which is stage of granuloma, so granuloma is formed in the nasal cavity, and that causes obstruction, and then that gets fibrosed. So then there is a fibrotic stage, which is called sclerotic stage. These two stages, they can cause obstruction. Again, it is usually unilateral, and by that, when it is sclerosed, the last stage, the entire nasal cavity is blocked. So when it is a stage of granuloma, then it's slightly difficult to diagnose, because it looks like a mass inside the nasal cavity, a red mass. It could be a tumor, it could be some other things like inferior turbinate hypertrophy and all that. So you have to be careful, and you have to diagnose that with the help of histopathology. But once there is sclerosis, sclerosed tissue is a fibrous tissue which is pale in color, isn't it? And the cavity is blocked. When there is sclerosis, it doesn't give you appearance of a mass in the nose. The whole nasal cavity is blocked, as if there is a door. There is a door in the nostril, it is blocked. So that kind of feel it gives. very easy to diagnose. Sclerotic part is very easy to diagnose. One look, you know it is sclerosed tissue, and we have seen sclerosed tissue in other parts of the body. So sclerosed tissue is never difficult for us to diagnose, but when it's granuloma, then it might be slightly difficult. But then you can take a histopathology, biopsy tissue, and do a histopathological examination. Everybody knows that two very popular cells, which are very commonly asked in the exam also. One is described as Mikulicz cell, and one is Russell body, isn't it? So when you see these two types of cells, Mikulicz cell, Russell body, straight away you know that it is rhinoscleroma. And this stage, when it is granuloma, it is also has one more name. It's called woody nose. The feel is woody hard. And in sclerotic stage, it is called Hebra nose, woody nose. These are the term we use. And once you diagnose, of course, you have to treat. You have to give antibiotics because bacteria, Klebsiella. So streptomycin is given as an antibiotic, and surgery has to be done. Some kind of surgery, maybe laser, maybe cortex and all that. You have to be careful about bleeding in this case. And rhinosporidis, I mentioned briefly, is another infective condition caused by Sebarii, rhinosporidis sebarii. And this opposite of rhinoscleroma is seen in the coastal area, southern India. Coastal area of southern India, especially in the state of Tamil Nadu. Overall, Sri Lanka has a lot of these cases. But this is a very typical presentation in adult, always unilateral, and it is described as strawberry polyp. So it's a strawberry. You must have seen. So it's a deep red, fleshy red mass. It looks like a polyp. That's why I discussed nasal polyp. The look is very similar to the polyp, but remember, polyp is pale. This is deep red, flesh red, and on top of it, there are white dots on it. White dots, and these dots are usually spores, they say. So because of that white dots, which is grayish dot actually, the look is like a strawberry, and it's called strawberry polyp. So easy to diagnose clinically. Once again, of course, CT scan has to be done, but treatment is again you have to remove this strawberry polyp-like thing with the help of surgery and give a medicine. Dapsone is given. Dapsone is a drug of choice in this patient. Now, one more cause of nasal obstruction could be atrophy rhinitis. Now, this is very strange, isn't it? The name is atrophic rhinitis, which means the cavity space is atrophied, but the most common complaint is nasal obstruction in this case. And the cause of obstruction is crust formation. Crust formation is the cause of obstruction in most of these cases. So again, the diagnosis is not easy because along with this nasal obstruction, there is a foul smell from the nose, there is bleeding on touch, and when you examine, you can see the room of the nose is increased. The term we use is roomy cavity, and it's dry cavity. So one look in the nose, you know it is atrophy straight away, and you can see that crust is black greenish thing. You know, when you dry, combination of dust and nasal discharge, greenish discharge, if you mix them and you dry it, that's kind of crust you see in this patient. That is causing the obstruction, and it's very bad smell from there. If you try to remove it, it bleeds a lot. The moment you touch, it starts bleeding. So not very difficult to diagnose, but very difficult to treat. Atrophic rhinitis, as I said, is not difficult to diagnose. It's very nearly impossible to treat, in most cases. So most of the time we do a symptomatic treatment only. So one thing is we can keep removing this crust, cleaning the crust so there is no obstruction. And for that we do what is called alkaline nasal douche, as you know, alkaline nasal douching. So douching does it what? It softens this crust, and the crust keeps falling down, and then you can manually also remove it because it's not going to bleed that much. So, and the patient has to repeat this alkaline douche regularly so that there is no fresh crust formation, and whatever crust forms will fall off easily. And then there are other things. There are so many causes of atrophic rhinitis. You have to find the cause and treat the cause. Like if there's estrogen decrease, you have to supplement estrogen. If there's decrease in the vitamin D, you have to supplement vitamin D. If it is infective, you have to give antibiotics like streptomycin. So really depends on the cause. And there's some surgical treatment also, Young's operation, Lawton's leg surgery on that. So very important to know that there are really a long list of causes of atrophic nasal blockade, and it's not very difficult to arrive at a conclusion and diagnosis, especially because you can see nose very easily. You can peep into the nose during rhinoscopy, and you can see almost everything. Even the posterior part of the nose you can see with posterior rhinoscopy, like corneal atresia. I did not mention here corneal atresia. Another cause of can be caused used as a cause of corneal atresia. Another cause of blockade in a newborn child. This is in a newborn child. This gets missed most of the time because often it is unilateral and partial. So if it is unilateral, the child keeps breathing from the other side, so there is no big problem. And it's partial. Even if it's bilateral, it's partial. So whatever the space is remaining, through that the patient keeps on breathing. So it's never really a challenge as far as breathing is concerned, but it's a challenge as far as diagnosis is concerned. Most of these cases gets missed. That's why, for those who know, that when the child is born, one of the first thing the pediatrician does is, after the pediatrician made the child cry, the pediatrician will try to clean the nasal cavity with the suction. They pass in the suction tube, and the idea is that they will aspirate all the secretion of the nose and all, clear the nose, so the breathing of the child becomes better. So one of the things, besides of course aspirating all the collection of the nose, one of the things that the pediatrician trying to know is there any obstruction in the nasal cavity due to anything. So they pass this suction tube right till the nasopharynx, even beyond that sometimes. So the suction tube must go freely without any obstruction. So if there is some resistance, some obstruction, then it gives them a idea that maybe there is some obstruction inside. And a very common obstruction in a newborn child could be corneal atresia. Now, how do you diagnose? Suppose a child has unilateral corneal atresia. So the child has been breathing from one side. So if the child is breathing from one side, most of the time we will not know that the child has a problem. So what do you do? How do you diagnose? One of the things is that when the child has a nasal discharge, from one side there will be more discharge because it is not, the nasal discharge is not going back, it's coming out. One side is no discharge because one side is open, so that all the nasal secretion is going to the nasopharynx. But the side which has nasal obstruction due to corneal atresia, that discharge is not going to the nasal cavity, so that discharge from the sinus will come out. So this child will have unilateral discharge all the time. Nose is flowing usually one side. So that should give you a hint. And the second thing is, normally you must have seen a child's nasal discharge. You must have seen so many kids with nasal discharge. There are air bubbles in them. There are air bubbles. But this child's nasal discharge will have no air bubble. It is pure water. No air bubbles. Because there is no air flow through the nose because the nose is blocked. So that air does not get trapped into this discharge. So one-sided discharge, and especially if there is no air bubble in it, it's a highly suspicion of this corneal atresia. And then you can of course do endoscopy or CT scan, diagnose, and you have to do surgical treatment of corneal atresia. Right. So this will complete this topic actually, and I thought I'll discuss few MCQs also related to this. Let's see how many MCQs we can discuss in this. I've prepared a simple one, 4 or 5 MCQs. So let's talk about them. Number 1, look at this. They're simple one. I have 5 questions. Let's see how many of you can. And because we have discussed most of it already just now, so it will be easy for you. A 5-year-old child is brought to OPD with foul smell in the right nasal cavity. On examination, dried pus in the right nasal cavity with foul smell. No other significant finding. Next best thing. Antibiotics, CT scan, remove foreign body, endoscopy. So what do you think? Please answer on the chat box so that I know A, you are active, and B, that you are following properly. See, foul smell in the right nasal cavity, one-sided, in a child around 5 years old with dried pus in the right nasal cavity is most probably a foreign body. I told you that up to 2 or 3 years there is no foreign body in the nose because the child is usually with the mother under supervision and all that. Once the child starts going out, play with a friend and all, chance of foreign body, hematoma and all increases, which is very common around this time, 4 or 5 years of age, because the child is experimenting. Why does the child put foreign body in the nose? Because the child's mind is developing and the child is curious about things, the child is experimenting. That's the whole idea. Otherwise, why should a child put anything in the nose? So the child is used to putting things in the mouth. We eat through the mouth. You see his parents eating through the mouth, his brother and sister eating through the mouth. And the child is curious कि मुंह में कुछ डाल सकते तो नाक में क्यों नहीं डाल सकते, कान में क्यों नहीं डाल सकते, So they'll pick up something and they'll put in the nose or the ear. That's a child's way of. There are two things. One is child's brain is developing, so the child's curiosity is there, and the child is exploring. It's like exploring. The child already knows कि मुंह में तो डालना होता है खाना, but the child doesn't know कि नाक में नहीं डालना था या कान में नहीं डालना. So the child is exploring. So that's a part of his development, brain development. And the second thing is, because some itching happens in the ear or ear or nose. So because of that, when the child puts something in the nose, temporarily that itching sensation goes away. So the child feels nice. It gives you a nice sensation, good feeling. For that it puts in the foreign body. So when there is a foreign body in the nose, you can't see foreign body in most cases because it is covered with pus. By the time child comes in, it is covered with pus, so you can see only the pus which is given in the choices. But anyways, if a child has unilateral foul smell from the nose, you don't even have to think of twice, it is foreign body, and you straight have to remove the foreign body from this. Yes, Madhu, you are absolutely right. You have to remove that foreign body. There is no use of antibiotics, there is no use of CT scan, and why do endoscopy? Because you can see there is something there. When you cannot see this pus and all, then you have to suspect that maybe the foreign body is deep inside, and then you maybe, when you can see something, even if it's dried pus, just behind the pus there is a foreign body. And for those who know that foreign body of the nose should ideally be removed under general anesthesia, not under local. We do it under general anesthesia. Right. Second question. A small child was playing outside the house and came running crying, was not giving any other history because the child was crying, and brought to the OPD. On examination, swelling in both the nasal cavities, not true about this child. Septal hematoma, must have trauma or fall, conservative management, endoscopy. So, not true about this child. What do you say? So perhaps, see, again a child came in crying, so must have got traumatized and all, and this is not saying anything because the child is crying, and there is a swelling on both the sides. I told you septal hematoma is always bilateral, it's swelling. So it is septal hematoma. It is very, very clear. Then must have had fall or trauma. It is immediate IND. In septal hematoma, we do immediate incision and drainage. So this is answer. Endoscopy may be required in sometimes when you suspect, we are not very sure. You are not very sure, then endoscopy may be required. But in most cases, we don't do endoscopy. But best answer is conservative management, because we have to do immediate incision and drainage in this patient. Yes, you are right, Avinash. C is the correct answer, conservative management. We do not. I just told you a little while ago that in septal hematoma, you have to diagnose immediately, because that's why endoscopy comes to play. When you have doubt, you cannot wait. Immediately put the endoscope C, make us sure, so that you can do incision and drainage plus nasal packing. Because otherwise it can become abscess, ischemia, necrosis, and septal abscess, septal perforation can happen, which is a very bad thing to happen. 13-year-old child, boy, was brought to emergency with epistaxis, had blood stains, nasal discharge for few days. On examination, nasal cavity is filled with clots. You can't see any swelling and all that. Mild swelling is noted in the cheek. Not true. I think it's very simple. Juvenile nasopharyngeal angiofibroma, antral sign may be positive, immediate surgery, nasal packing. So what do you do? Not true in this patient. 3 are true, not. So this is a case of angiofibroma, because age, boy, bleeding and cheek swelling, and had few stains in the nose in the past. So it's straight away the case of juvenile nasopharyngeal angiofibroma, and that's why antral sign must be positive in the, because it is cheek swelling. So if the tumor has gone from the nasopharynx to the cheek, then antral sign in most patients will be positive. And because the patient came with bleeding, you have to do nasal packing to stop the bleeding. So surgery is, how can you do a surgery immediately for a tumor? You have to first investigate, confirm, stage. In tumors, all this has to be done. You have to confirm first, then see the extension and all that, stage the tumor, and then you decide the surgery. So obviously, for no tumor do you do immediate surgery. So this was simple one, right? Not true of on-grains line. Again, it is for maxillary carcinoma, helps in deciding treatment, not commonly used nowadays. And tumor below this line have a good prognosis. Straightforward, simple, I think B. On-grains line is indeed used for maxillary carcinoma, but it is used to know the prognosis, not for treatment. Above the tumor, bad prognosis. Below the tumor, good prognosis. D is true because below the tumor has good prognosis, and it is useless thing nowadays because we have CT scan and all that. Why go with this useless thing? This question was asked 3-4 years back after a very, very long time, and I suspect the examiner must be very, very senior. During his time or her time, maybe this was very important. But this ongoing line has lost its relevance more than 10-15 years back, and suddenly, and I had stopped teaching over this around 10 years back. I stopped teaching ongoing line because it was irrelevant, and suddenly 4 years back a question popped up in one of this exam or in NEET exam, and so again we started teaching because you never know, your examiners are very elderly people sometimes, and they'll give you things from their time. So option C, prognosis about what? Prognosis about what, Avinash? Angiofibroma has a good prognosis. It's a benign tumor. If you're talking about angiofibroma, and benign tumor usually have good prognosis if you know how to do surgery properly. Surgery is difficult, but prognosis is not bad. And the last question, a patient with nasal mass and epistaxis off and on, not a differential diagnosis in this condition. Patient has nasal mass with bleeding off and on, which is not a differential diagnosis. Nasal polyp, juvenile nasal angiofibroma, inverted papilloma, all are possible. So this one is simple, I think. You can do it. Most of you can do it. Please go for it. I told you nasal polyp will never have epistaxis, isn't it? Nasal polyps do not have blood supply. Yes, absolutely right, Avinash. So epistaxis in nasal polyp is usually not seen. So if there is a bleeding from the nose, it cannot be nasal polyp. Very straightforward. So that should be it today. I think we have covered a very important topic, and thank you for being interactive in audience. Tomorrow same time again I'm going to have one more session on YouTube, and this session is going to be MCQ only. I'm going to take MCQs which are relevant for your PG NEET PG exam, this coming NEET PG exam. All the important points. There'll be a mixture of clinical based question, image based question, and one liners also. And I'm going to take maybe more than 10 to 15 questions, anywhere between that. So please don't forget to log in at 9 o'clock same time tomorrow morning. Till then, goodbye, thank you, and have a very, very nice day. God bless you.